Respected Chairman and learned audience, Assalamu alaikum and very good morning. Welcome to my case presentation, and thank you to IPDI. Thank you to IPDI to giving me the opportunity to present my case. So I will tell you the 32-year young male was in a dire strait with palpitation presenting in our hospital. So the 32-year young male with no known comorbidities was presented to the electrophysiology unit of NICVD with the complaint of recurrent episodes of palpitation for the last 2 years. It was not associated with chest pain or any shortness of breath or any syncope, or there is no precipitating factors. History of recurrent hospitalization with this type of symptoms and which made him panic, including his family members. He had no history of any sudden cardiac death in his family. During initial presentation in the local hospital, the ECG was like this. The ECG was showing that the rate is very high, that is rate is around 300 beats per minute, and rhythm is regular, but the QRS is very wide, and it is about 200 milliseconds, and also it is the LBBB morphology, and there is some P waves are there, and make it the diagnosis to AV dissociation. So our ECG diagnosis was the regular white complex tachycardia, regular white complex tachycardia, most likely ventricular tachycardia. According to the document given by the patient that time when he was presented in the hospital, local hospital, he was hemodynamically stable and he was treated, and the sinus rhythm was reverted to sinus rhythm by injection, amiodarone 150 milligram IV bolus, followed by maintenance dose. The sinus ECG was demonstrated that the T wave inversion in the V1 to V4, the significant T wave changes, and otherwise the normal findings. At that hospitalization, the other blood reports showing the normal findings, only the troponin I was raised, and it was positive. His chest X-ray PAV was showing mild cardiomegaly. And that time, bedside echo was done, which is showing that the inferior and posterior wall was mildly hypokinetic, and also there is the right atrium, right ventricle was dilated, and there is the mild LV systolic dysfunction and some sort of mitral regurgitation and tricuspid regurgitation was there. And also they noted that the moderate band was evident in the right ventricle. Accordingly, the patient underwent coronary angiogram at that hospital, and which reveals that the normal coronary epicardial coronary arteries. With this, the patient was referred to our electrophysiology unit of NICVD, and we handled the patient and we assessed the patient at that time what we had in our hand. That is, we assess further with such young patient with the ECG like ventricular tachycardia with LBBB morphology with superior axis, in sinus ECG showing that is the T wave inversion in the V1 to V4, and the echo was showing some sort of wall motion abnormality and the mild LV systolic dysfunction, also right-sided chamber dilatation, and the coronary angiogram showing the normal epicardial coronaries. So in our department, we want to further assess the patient, and keep in our mind in our differentials was the first differentials was the arrhythmogenic right ventricular dysplasia and other some scar-related ventricular tachycardia. And also kept in mind it is sarcoidosis or other infiltrative diseases. Accordingly, we put the patient to echo, and we did the echo meticulously, which showing that the RVOT is hugely dilated. It is 56 millimeter. In plaques view, and so short axis view also dilated to 43 millimeter. In apical four-chamber view, right ventricle was dilated and also hypokinesia and some sort of aneurysmal dilatation in the apical part, and there is the extensive trabeculations including the moderator band is noted. So our diagnosis was the more likely to the arrhythmogenic right ventricular dysplasia. We advised the patient for the cardiac MRI, which also showing there is the dilated right ventricle with the fibrofatty replacement of the right ventricular apex and also some dyskinetic part of the basal and middle part. And there is also delayed gadolinium enhancement is noted in the multiple areas of the RV, which suggests the scar or fibrosis. nerve ejection fraction also reduced to 38%. So according to the revised task force 2010, our diagnosis confirmed that the VT with the left bundle branch morphology and also the superior axis, also the 2D and cardiac MRI also suggestive of the it is arrhythmogenic right ventricular dysplasia. So it is very much difficult case, and it is always feel pleasure for our to diagnose such a rare cases of ARVC, and we put the patient also the cardiac ICD implanted. ICD was implanted in our center, and the patient was doing well for the last 6 months. Thank you for patient hearing.